Well, good evening, everyone, and welcome to our presentation tonight. The presentation is optimizing a PowerPoint, taking us from student learning to professional education. I'm Kathy Baldwin, and I will be facilitating this call tonight. And my credentials are listed there for you, and I am the current FSHP president for 2 more weeks. So just a couple of housekeeping notes. Slides will be posted on the webpage shortly hereafter, probably not tonight, but probably by next week. This is not a CE presentation, and I want to ensure that no one is disappointed by stating that the target audience focus tonight is on residents, students who want to do residencies, students who want to do residencies, and pharmacists who want to just upgrade their PowerPoint presentation skills. I want to share with you, and this is not a very good picture, but this is a copy of a very large piece of paper that I have, a very expensive piece of paper. It is my master's degree of arts in adult education. So it's very different than what we call pedagogy or childhood education. And our objectives tonight are to discuss the importance of establishing buy-in to pharmacist learners when pharmacists or students present to other pharmacists. It's very important that we know and understand the target audience. We're going to spend quite a bit of time on that. And then to actually look at guidelines on slide development. And the Harvard School of Public Health put out a very nice presentation on slide guidelines. And then we'll round it out by finishing up with the color of learning in information transfer. The first thing I want to do with you is role model buy-in. So if you'll notice, I talked a little bit about my master's degree in adult education. I'm a pharmacist, and therefore I'm a content expert in this topic. And I want to put that out there to everyone, because one of the things that pharmacists need to know when you're presenting, whether you're a student or resident, is why should I listen to you? My time is very valuable. I am bombarded daily with 50 emails about drug information. Why should I give you the time that you're requesting of me? And I want you to tell me that straight up. So when I attended a grand rounds recently by a resident, the topic was bone marrow transplant. And I thought, I work in an ICU. What if a bone marrow transplant patient had a complication and came to my ICU? I better go to this presentation. So I went to the presentation, but I thought, oh, the likelihood of it happening is probably not that high. And so at the very end of the presentation, the resident made this statement. Well, we are going to start taking bone marrow transplant patients at our hospital, and we are going to start doing these procedures. It was my hospital. And I sat up and I said, oh no, if I had known that from the beginning, I would have blocked everything out and given her my complete attention. So I think it's important that we establish buy-in as to why you want to spend this time with me. And so tonight I will say to you, I am going to marry adult learning methods and my adult education degree with pharmacy and present to you from that perspective. So I have just established buy-in with you. The number one rule, and when you see my formatted slides like this, this is a take-home message. Know your target audience. So respect the baseline knowledge of your target audience. And if your target audience is pharmacists, then you want to recognize their level of proficiency and you want to add to it rather than present basic facts about things. So we're going to talk quite a bit about that because that is a very important take-home message here. The pharmacist target audience, our goal of these presentations to pharmacists is that we can learn something and that we can learn things that are immediately applicable. This is very different than student learning. So students who are on this call will recognize, and those of us who are older can remember, that in school, you get a bunch of information, and then you may not see it again until the test, and then until you're in clinical practice. You're on your IPPs, your APPs. So you're willing to wait to apply that information. But I'm going to retire in the next 3 to 5 years. And so I need to know this stuff like right now. If you give me new information and I'm not going to use it right now, I'll put it aside, but I'll remember that you gave me that information and I'll go back and I'll look at it at the time I have a patient. So the whole goal of pharmacist education from students or from residents is to take from the learning environment back to our places of work and apply it. So we want to know new information, things that are relevant. We don't want to know old information. So I recall a student presenting on HIV, and the student walked me through a historical perspective of HIV and AIDS. And I thought to myself, here's someone who was born 20 years after the HIV AIDS crisis, which occurred in 1984 when I was a pharmacy student the first time. And then I remember going through the Kimberly Bergalis situation and the Ryan White situation and the whole national country being gripped by HIV and not understanding if it's a pandemic like what we just came through. Is it limited? You know, I remember all that fear and trauma affiliated with HIV. And the student poised herself to be an expert in the background of HIV. And I thought, I've lived through this, but you're presenting to me information that you read about. So you're really not the content expert. So you want to stick to things that you can become a content expert in. Another example of this was a student who had presented on ACE inhibitors in diabetic proteinuria and the role in prevention of the progression of kidney disease. But this was 10 years after all these papers, and I think it was the HOPE trial, the micro-HOPE trial, I'm not even sure I remember them anymore. But the bottom line is it had been a well-established practice for 14 years. And so when the student presented and he said to me, how did I do? I said, well, I'm a little bit confused because this is all old information, a historical perspective. I wish you would have told me about something new about ACE inhibitors and proteinuria. So that brings me to the next question. I have to move my bar here, if you'll excuse me for a second. Oops. We're going to talk specifically about historical perspectives and how not to get hung up on them, but how to frame them so that you can move on to the conundrum or whatever the topic is you're going to discuss and the solutions. So I do want to talk about mechanisms of action. I will go to presentations and the students will teach me how aspirin works. But as a pharmacist, being in the target audience, I know how aspirin works and I know the studies. So things that may seem new and exciting to a student or to a newly graduated student, a resident, may not really have or be applicable to a pharmacist presentation. So always ask yourself, is this a new mechanism of action? Does this target audience already know this mechanism of action? And some of the pharmaceutical companies, when it is a new mechanism of action, have awesome videos that you can take and put in your presentation and show us this is a new mechanism of action. And that's why I want you to be able to see it and to experience it. So Mary Lynn Schruck from Lee Health is on our critical care FSHP component group. She does dynamic presentations on mechanisms of action. She only presents when it's a new mechanism of action, and she makes everything animated. And I'll demonstrate that principle for you towards the end when I give you a mini grand rounds. Oh, my slide is stuck. Okay. So this is mostly students and residents. It's important to recognize that pharmacists are functioning. This is Bloom's level of taxonomy, minimally at the application level. But typically I live in the ICU at evaluation and synthesis and creating. And so if you come to me and you present something on basic knowledge or comprehension, I already have that. So you have to consider this with your target audience. Where are your target audience already functioning? And where can you contribute to their knowledge base? And it is possible, because I think my student Taylor is on here. And the other day, she contributed greatly to both my physician's practice and my practice when we had a patient who had attempted suicide and she was taking Montelukast therapy. And Taylor said, I don't think that's a good idea for this patient because of its neuropsychiatric black box warning. And I said, what? And I hadn't picked up on that. And guess what? The pulmonologist hadn't picked up on it either. So it is possible to contribute to the knowledge base, even as a student on your rotations. So just to acquaint you, if you're not already acquainted, there are active verbs that are based upon each level of Bloom's taxonomy. Looking at different things and you can Google this, you'll find it. These slides will be on the internet. Knowledge, understanding, application. Sometimes they use different words here. But my word to students is always hit for the application level. And my word to residents is always hit for the higher levels. Analyze, evaluate, and create. But when presenting to pharmacists, keep in mind that we have knowledge, we have understanding, and we get it. So you may have been taught at those levels, but there's no need to teach us at those levels. So presenters should be content experts. And the way that you become a content expert is you immerse yourself in whatever the disease state is that you're talking about, or the drugs that are being used. I went to a residency presentation, and the student presented all the literature, but had never seen a patient case. And it became very evident that the presenter was not a content expert. So to be a content expert, you really need to immerse yourself in seeing multiple patients with the disease state that you're talking about. So in this particular case, it was about stroke, and it was just a compilation of this is what happened in 1990 with the NINS trial, and then other trials that came out afterwards. And I think the drug is dangerous because, and the bottom line was, I'm not a content expert. So that's a pitfall that you want to avoid. You really want to present at the application level at a minimum. So I'm going to ask everyone a question if you want to put it in the chat. What is the average number of minutes an adult learner will listen passively during a lecture? Is it 2 minutes, 6 minutes, 10 minutes, or 15 minutes? How long will I have your attention by just speaking to you and not engaging you in the presentation itself? Good, we're getting different things here. Well, the bottom line is it's a short amount of time, right? And the literature and what I was raised on, get back here, was 6 minutes. So you will agree to listen to me for 6 minutes, and then you will think about your dry cleaning or what you had for lunch or what you're going to have for lunch, and I will lose you. So we're going to optimize our slides, and I will demonstrate for you how to do that. So looking back at adult education, there are methods of information transfer. Some are very strong and some are very weak. So let me orient you to this slide. Discussion is the weakest level of information transfer. And lecture in PowerPoint is the second weakest level of information transfer. And then, oh, I'm going backwards, excuse me. Group discussion is a little bit higher. Role modeling and role playing. Now we're starting to make some gain here. Demonstrations and simulations. CPR is a demonstration and ACLS is a simulation. Case study, and this is where it becomes very interesting. This is storytelling. So I can remember back in 1982, my history teacher telling us stories about not having electricity and people going into hotel rooms and taking a match and trying to light an electrical light. They didn't know to turn the light on, the switch, because they were so used to candles. They went into hotel rooms, and the hotel rooms had the best and the newest and the greatest. And they would try to light the candles when all they needed to do was flip a switch. I also remember there was a president and he never said more than 2 words. And a reporter sat next to him and said, "My colleague said that you will not say more than 2 words to me." And he looked at her and he said, "You lose." So storytelling has a very high level of reference and memory. And storytelling in pharmacy is called case studies. Oops, going the wrong way. And then, of course, APPE is the highest. You read about it, you see it, you involve yourself in it, and then you teach it to someone else. And so to show you that starting at the bottom and moving up, we increase information transfer or education. It is the highest level. So I want to make one other point about this slide, and that is role modeling and role playing. I see students and, of course, new pharmacists, residents, teaching us through PowerPoint the way that they've been taught, because role modeling and role playing has a medium level of information transfer. And that is why I want to do this presentation for you tonight, because I want you to move beyond that and go to case studies. Don't just give us literature, give us case-based application, and we will remember things forever, just like I did with those history stories. So PowerPoint is considered passive learning, and we can actually make it more active learning through case-based presentations. So I'm going to demonstrate now for you as we go from passive to active learning. It's going to be like an eye exam. Do you like the first slide better or the second slide better? So this was a presentation I was doing when CHADS 2 VAS score came out, and I was applying it to a patient, and she was misjudged because the scoring had not been changed to the CHADS 2 VAS score. So I could present it in this manner. She was a female patient. The CHADS 2 scoring didn't capture her. She was between age 65 and 74, and that didn't capture her. And so we needed an updated scoring system. Or I could show you this. Well, here's my patient. According to the CHADS 2 score, she had hypertension and she had 1 point. But according to the CHADS 2 VAS score, she had hypertension. She was age 67 and she was female gender. Sorry, I got my little arrows out of sync there. What's easier to receive? And absolutely, it's the second slide. So let's do that again. I could tell you that my patient developed a rash after titration of valproic acid and lamotrigine, and there's a severe interaction when not titrated properly. Or I can show you a picture. This is a severe rash. Although my patient didn't demonstrate this particular rash, this is a side effect when we don't titrate lamotrigine up slowly. And always put your references at the bottom of the slides, and I'll tell you why I say that. When I go to conferences, I will go back and pull up certain slides. And when I go to the last page and there's a bunch of references on there, I literally spent 3 hours one time going through every one of that back page references looking for a reference that I really wanted and could not find. And had it been presented on the slide itself, it would have been so easy for me to cut and paste, put that in there and get that reference. So always put your references at the bottom as they apply to that particular slide, for the sake of the pharmacists who are like me and want to go back and look at the actual literature. So I could tell you that doses vary on valproic acid and lamictal doses will vary if you're on one enzyme inhibitor or if you're on an enzyme inducer. And the differences are 25 milligrams every other day, or sorry about that, or 25 milligram daily. Sorry, that's a typo. Or I could show you the reason that doses differ is because of the potential for severe adverse skin reactions. And this is what the doses look like. My patient in particular was taking valproate, so we followed the starter kit. So the whole point to these two slides is to show you to go from passive learning to active learning. So this engages you, and you're going to be reading my slides. Slides will always be read, which will bring me to another point shortly about the role of slides. So again, I can tell you the INR increase became super therapeutic on day 3, passive listening, or I can show you active listening, active engagement, active learning. I love this slide because it's very old, but I used to practice in stroke and in neuro, and it is exceedingly comprehensive. And my reference is at the bottom. If you want to pull it, you can pull it. But it allows me to talk about a lot of different things and show you, and you're going to actively engage in this slide because you'll be reading it. And you'll remember, oh, so-and-so presented on that. I want to go back and pull that up when you are in need of that presentation. So it's tough to get this PowerPoint if you Google Harvard School of Public Health, but if you take this link and put it in Google, it just downloads the slides for me. So I've been using this for a long time, and Harvard School of Public Health recommends the 6x6 rule. That means no more than 6 words apart, across, and no more than 6 thoughts downward vertically. Keep one topic per slide and use your slides as outlines. As I think we just observed, when I passively talk, people will listen for 6 minutes, then they're gone. But when you have slides that actively engage people, they will read them and pay more attention to them. So your slide, people are going to read your slides no matter what's on there. What you want to do is keep your slides limited to no more than 6 words apart or 6 thoughts down, one concept, and you want to keep people, you don't want them reading everything that you want to say, because they'll read your slides and they will never listen to you. You're the presentation, and the slides are a reminder to you as to what to say. So let's take a moment and talk about historical perspectives. Historical perspectives are great when you're presenting, a relatively a relevant situation. So I went to a presentation by one of our residents a few years ago, and this was what the presentation looked like. And in 1912, phenobarb was introduced, and in 1930, phenytoin was introduced. But I want to bring your attention to this. The Epilepsy Society had this great slide, and it's much more active engagement than passive listening. So timelines really do well for historical perspectives. The interesting thing about this presentation that I went to, and this was one of the slides, was that the entire presentation was about the history of major anti-epileptic drugs in the United States. And when it came to the newer drugs, there was no time to discuss them. So we had a drill down at that point with the resident to say, you know, we really wanted the new information, and presenting a slide like this would have saved you 25 minutes. Another great way to show clinical trials, I love this format. Rather than being wordy, yes, it does have a little more than 6 by 6, but while you're speaking, I'm going to be reading these and I'm going to be actively engaged in these concepts. And another great way to show trials. We talked about the slide content and the 6 by 6 rule. For the students, always make sure you use generic names and you give proper, you know, you'll talk about the patient's drug therapy in the hospital. Always give a complete order and use appropriate, like you don't use U for units. This is all kind of old stuff. Use correct abbreviations. So remember that slides are a reminder of what you want to say, and they are not the presentation themselves. The Harvard also talks about the PowerPoint guidelines about clip art, and it says don't use clip art unless it is absolutely necessary to make the point that you're making. So it's okay to have different diagrams and things in there, but clip art for the sake of clip art has no role in professional PowerPoints. So one of the things we can do is take people from passive to interactive by presenting therapeutic conundrums. Current issues at hand that can be presented quickly. So we have this issue. We have seen it in 25 patients. And so we are here today to discuss this issue and to see how we can remedy it. Pharmacists are all about the solutions. We know what the problems are. We want solutions, and we want your presentations to teach us that. Consider issues relevant to the learner. So there's a learning concept called just-in-time learning, and I alluded to it before. It means that we want to be able to learn from you, go back to our workspace, and apply it to our patients. And I remember one time being at FSHP and somebody presented this concept, and I don't even remember what it was presented in. But I said, wait a minute, this is a problem in my daily practice. And Zosyn and vancomycin compatibilities, the whole hospital is on Zosyn and vancomycin. And so what is the issue with compatibilities? And so they mentioned at this concentration, it's compatible, and at that concentration, it's not. The only thing I heard in that 1 hour, I put it in my iPhone, look up Zosyn vancomycin compatibilities. And I went back and I taught it to my nurses. And that's the kind of stuff that we want to take home from presentations, things we can apply immediately. So if you're a student or a resident, you're not sure what to present on, ask your pharmacist, what is it that you would like to know about? What issues are you struggling with? And set out to solve those issues. And use cases in doing so. So I'm going to quickly give you a therapeutic conundrum and frame the issue. You give, hey, this is the problem, but let's move on to what the solution is. So I'm going to demonstrate for you very briefly. This is a very old presentation, and I don't want you to get the clinical value out of it more so than the educational value. But I'm going to role model this for you right now. Hi, everyone. I'm Kathy Baldwin. I'm here today to talk about intracranial hypertension. We're going to focus on osmotherapy. We have a new neuro ICU in our hospital. And so we want everyone to be on the same page as we are for those who work in this neuro ICU. Please put your pagers and things on silent, and we will make the slides available at the end of the presentation. So what I'd like to do is start by justifying the role of more than one gold standard in the hospital. My therapeutic conundrum is, can we have 2 gold standards? One based upon ICU, neuro ICU, and one based upon ED and other aspects or other areas in the hospital. And then I'm going to compare and contrast different osmotherapy agents And then we're going to talk about efficacy and toxicity monitoring for what we're going to be using in the neuro ICU. So I'm going to remind everyone, we all know this, gold standard is superior efficacy, relatively well tolerated, most commonly used, and safe. It must be safe. So my question to you is, can two gold standard exist in this area of practice? My neuro ICU and the ED and the rest of the hospital. So let's look at a case. This is a 59-year-old with an intracranial hemorrhage, came into my neuro ICU. We did everything right. We put in a ventriculostomy. We kept the room dark and quiet, kept the patient relatively calm. And you can see here our maps and our ICP pressures. Our ICP pressure is dangerously high. Oops, excuse me. So intracranial pressure reduction consists of neurosurgical evaluation, ventriculostomy, resting the brain, maintaining cerebral perfusion pressure. Our focus tonight is on osmotherapy. We can also utilize barbiturate coma, and we can think about what is called today as therapeutic temperature, target temperature management. So my goal for this patient is an ICP of 5 to 15%. We are going to use 23.4% sodium chloride via a central line because that's the only safe way to do it. We're going to do it every 4 hours. We are going to optimize normal saline, and we are going to change everything out of D5W and into normal saline. And we're going to try to keep our serum sodium at 155 or less. These are our three basic ways of achieving that, but we are going to be focusing on the center. And so our monitoring plan will match that of the center column. And this is a comparison between mannitol, which we use elsewhere, and hypertonic saline in the neuro ICU at this high concentration. So because my target audience is non-neuro ICU patients, I think non-neuro ICU practitioners, I think it's okay to present this. And so when we do 23.4% sodium chloride, we are putting sodium into the vasculature. Same thing with mannitol. So in the ED, we're doing mannitol, and the whole goal of therapy is to suck volume out of the brain and put it into the kidneys. And limit D5W because it basically is pushing all kinds of volume into the brain. So my goal is a reduction of 13 millimeters in mercury in ICP, and that will maximize cerebral oxygenation and reduce a shifting of the brain and herniation. So here's my patient. Here's what my baseline labs were. Here's what they were 4 hours later, 8 hours later, 12 hours later. And then in the next morning, I was above goal. So we stopped the plan. Whereas mannitol is dosed differently, the biggest benefit to mannitol is that you can use a peripheral vein and you do not need a central line. And that's what makes it the osmotherapy of choice for the non-neuro ICU patient. Central line in neuro ICU, non-central line elsewhere, use mannitol. And so mannitol remains the gold standard outside the ICU. There's good efficacy with both drugs, but there's less potential for harm. And so the standard in the ICU, because we have a central line, is 23.4%. So very briefly, I just wanted to show you that was a new mechanism of action for most of the participants in the room. And so I did include it in that presentation. So I'd like to come full circle now and tackle the color of learning. So as you can see here demonstrated for you, have good contrast. And that is one of the rules of the color of learning. And the next rule is people will remember things if the color matches the color in life. And the reason I put these two blue bars in the center is because as we get older, we lose our ability to discern greens from blues. And that's just a normal aging thing that happens to us. But if you want me to remember the Christmas tree, make it green and don't make it red. And green typically means go, and red typically means stop. So blue-green, I want everybody to focus on this slide, take a deep breath, and tell me how you feel. Because blue and green are very calming. I try to use these colors whenever I present. Now, how do you feel here? Do you feel calm, or do you feel more angry or hungry? Orange is the color of hunger. It makes people hungry. When I had an office at my hospital when I was downtown, the wall in my office was orange. And I said, oh dear God, I'm going to eat incessantly. This is going to make me hungry. And if my memory serves me correctly, and I think that it does, there was actually a study on nursing home patients, and they gave them orange plates. And if I recall properly, and I meant to Google this before I spoke to you, but I forgot, patients ate more on orange plates than on other colored plates. Yellow and red, wake up, get going. So they're more energizing, but they really kind of don't have that calming effect that the blue and the greens offer us. So to enhance memory, you're telling a story in chronological order, you're making connections. You want people to remember something as a stop or a yellow or a green, utilize those colors because that's what we're used to in real life. So to demonstrate for you here, I'm showing the different pharmacologic dosing curves after one dose of an opioid. And when we do IV dosing, we have to be very careful because over the first 10 to 15 minutes, really to 30 minutes, we can get very high peaks and we can cause side effects if the dose is too high. And those side effects can even include respiratory depression. But if you compare that to oral, you see that we get half the peak and it takes about 15 minutes longer. But the benefit is that it lasts longer. And so we really want to employ these dosing strategies whenever possible. Lower doses, oral medications last longer and are safer than high dose IV medication pushes. So I've talked mostly about pharmacists and content, but of course, when you present, and I know Stephanie is on here, we want to have people come to FSHP and present at the state level once you're comfortable presenting at the local level. So if you want to be a presenter, you want to become not just a content expert on the topic, but a presenting expert. So it's very important that you pace yourself. The rule of thumb is 1 minute per slide. Use tonal inflections, avoid monotone. Remember to engage the audience, avoid passive learning. No, you want to use tonal inflections, stay away and avoid monotone, engage the audience, get excited, and the audience will get excited with you. Remember those concepts about passive learning and go for active learning. PowerPoint presentations themselves are low on active learning. So you've got to spruce them up and make them more fun, make them more engaging. And I have to move my bar again here to see, be passionate and have fun. Always ensure that you have a comfort level with presenting. You never want to get up in front of the state and not have practice or not have or not feel comfortable. Everybody's going to get nervous. It's normal. Public speaking is the #1 fear that people have in their lifetimes. People are scared to death to present. It's okay to be afraid, but practice, practice, practice. I think tonight I had to have a Diet Coke so I didn't fall asleep. I don't even get tachycardic anymore. It's like, let's just get together, share some information, and have some fun. And so that really is the goal. We want to learn, but we want to have fun doing it. So with that, I am done with the didactic portion of this. I think Viwac, are you on here? Maxwell said he felt hungry. Yeah, I get that too. I do like that blue slide. Why don't we hang out there? Give me 1 second here. Sharing your screen. So I was going to ask my student, and I want to see if you're on here. If you are, oh goodness, what have I done? Stop the share. Let me go to the right slide and pull it up, and we'll have a nice calming effect. And I'll be right back. Share the screen. Oh, no. Okay, it's not going to work for me. But now I want to hear from you. Is my student Viwake, are you on the call?
Yes, Dr. Baldwin, I'm here. Hi.
Hi, okay. I miss you. I want you to know that. I want everyone to know this young man. He is a spectacular student. He is a true healthcare provider, and he really cares about the patients. So are we able to see you?
I tried turning on my camera earlier, but I don't know if something's wrong. I can't, I'm just able to talk, I think. I'm sorry.
No, you're fine. So share with us, because you did a presentation and then you utilized the principles in here. Tell us the difference.
So yeah, so the first presentation I did, it was for internal medicine. It obviously was associated with a case, but I went a little ambitious in that presentation, trying to target like 3, not disease states, but 3 different conditions per se. And it was a great, there were multiple question and answers obviously at the end. But something that I learned after going over these slides that we just went today is how to streamline a presentation based on your target audience. Like Dr. Baldwin mentioned, there are mechanism of actions, and if you're all pharmacists, or at least we have attended pharmacy school, we all know what the mechanism is. So that is not something what you would want to be mentioning or presenting while you do a presentation. So you want to add something to your presentation which is based on the target audience, something that's new for them, so they are engaged in your presentation. And it's not just about saying what's on the slide, but also actually talking about some data. So one of the things that I implemented in my second presentation was there were 2 new drugs or therapeutic products that came out as a measure that were used as a prevention for C. diff for those who already had C. diff in the past. And those were 2 new meds. That one of them was an enema that was approved last year, versus the other one being a capsule that was approved this year. And that was something that that I added to the presentation. When was it approved, the cost of it, how it's meant to be administered, and some data that was published as a study. And that was very intriguing for the pharmacists, because nobody was aware of those therapeutic products being available on the market. And they directly started talking about how that can be implemented into outpatient setting versus into a hospital, and how it can be brought onto a formulary. Something else that I also learned was how to build up on your objectives. So the Bloom's taxonomy, the table that Dr. Baldwin showed, I think that helped me immensely, because it tells you what stage of the career you're on, and that helps you to pick those words and implement those into your objectives, so the audience actually knows what the presentation is going to be about. And also the six slide rule, that was a great suggestion, I feel like, because it does not make your slide boring, and it's also pleasing to the eyes for the audience as well. And those were my, I think, my best takeaways from all the suggestions and the guidance I got from Dr. Baldwin.
So after you presented the second time, how did you feel the pharmacists, was it well received?
Yes, in that sense, yes, obviously everyone was very engaged. I did have questions at the end, but they were not as extensive as what I had in the first presentation. Not that it's highlighting that I did not disseminate all the information that I wanted, but I think it was more effective in the way I disseminated information, since it was more streamlined and it was more up to date. Most of the questions were in a sense where what was the cost of the product versus how do you think, what do you think about the data, stuff like that. And I feel that is something that you would want to look forward into a presentation and keep everyone involved. It may not always be true to ask questions, and that may not be the best scenario of like asking questions would not be the most engaging way. Sometimes you present something new and that kind of catches the attention of the audience. And I think that's the deal.
That's the deal. I think you said it exactly. We're spending time, and so we want you to teach us something. And you did. You taught us about 2 new drugs because we're limited by a hospital formulary we'd never seen before. And we're like, whoa, we better listen to this. Somebody might come in on this medication. I need to know about it. So thank you for sharing that. You're a great student and you'll be a great pharmacist. I'm very proud of you.
That's about it.
Any comments from anybody?
I have
Denise.
one. Yeah.
Sure.
So first, I want to thank you for presenting this, and I'm excited to see students on. In my new role as the director of experiential preceptor development within NSU, I go out on a lot of site visits and get a lot of preceptor feedback. And a lot of the feedback is around what you presented today, that students are struggling to deliver great PowerPoint presentations. So I think this is really important. One keynote that they brought up, especially during residency interviews, is know the content on your slide inside and out and be prepared for questions. A lot of feedback I got is the presentation went well, then Q&A, and a preceptor may ask a question about something on a slide, and it may not even been the focus of the presentation, but it's on a slide, and then people couldn't answer it. So if you're going to put something on a slide, be prepared for a question. So I think that's the only thing I wanted to add.
That is really pertinent. Thank you for that. What this presentation is, you're saying I'm a content expert in this, and that the assumption is if it's on your slide, you own it. So great feedback. Thank you, Denise. Anyone else?
I also want to say that I really enjoyed the presentation and feel that it was very beneficial and suitable for the audience. I do see some of our students and residents on, and our residents just started about a month ago. So it's very important for them to know the skills that you mentioned, and it's going to be used a lot, definitely for residency candidates. We actually have a symposium coming up in September. And so there were really good points for our speakers to have in line as well. So thank you so much, Kathy.
And thank you, Carla, for helping me put this together. We're going to have this on our webpage, and you'll be able, the students, the residents will be able to watch it. And even Stephanie, people who are getting ready to present at the state level, case-based presentations are always very high level. And so maybe this will help them in some way as well. Kind of a broad target audience, making sure that we're raising people up with the right concepts. So Stephanie, did you want to say anything about FSHP and the Ed Council, or anything about the annual meeting coming up?
Well, the annual meeting is just a couple weeks away, so we're just in the very final preparation phase of that, and we are excited. It's going to be some great content. I hope that everyone's registered and can come join us. It should be another wonderful meeting, so we're thrilled. And I want to reiterate to Kathy, thank you so much for this presentation, and thank you guys for recording it as well. I think it's something that can be beneficial for those of us who precept to be able to have as recording to future residents and students for them to be able to utilize.
Super. Any last minute questions? And if not, we'll conclude. Anyone? Don't be shy. We're a friendly bunch.
Hi, this is Alex. No questions. I just want to say thank you so much again for the great presentation. And as a preceptor who has also struggled with students and having them do good presentations, it provides a lot more insight, and also the why of certain things, that of how a presentation should go, to better explain and mentor the students. So appreciate that. Thank you.
Thank you for that feedback, Alexandra. Any last comments? All right, it'll be posted shortly for you along with the slides, and you can share as you see fit. So thank you everyone for spending this 1 hour with me on this Wednesday or Thursday evening. I lost the day I was off. And I look forward to seeing everyone at the annual meeting. Thank you so much. Good night.
Thank you. Good night.